Menstrual cycle, AUP, then your menopause, PCOS, and we are going to talk about secondary amenorrhea, right? So let's quickly revise all these things. So first of all, gametogenesis. Gametogenesis, with the first question is germ cell. I will be revising this with you in normal sexual development. That SRY gene is located on the short arm of one chromosome. So if SRY gene is present, then the sex of the baby is male baby, and the germ cells, they form spermatogonia, whereas if SRY gene is absent, in other words Y chromosome is absent, so the sex of the baby is going to be female, and the germ cells are going to form oogonia, right? So first we are going to talk about spermatogenesis. Spermatogenesis begins with spermatogonia, the chromosome number being 46XY. This spermatogonia is going to undergo mitosis. Now, this is something which I want to tell all of you. So many times we are all thinking that all advanced things are going to be asked from us, but please understand, these days a lot of stress is being laid on the basics as well. So not only we need to know the advanced things, you have to have your basics strong. In this NEET PG, many basic questions were asked, and similarly in INI set, they have started asking very, very basic questions, right? So spermatogonia is going to undergo mitosis to form primary spermatocyte. Chromosome number remains the same after mitosis, so it is going to 46XY. Undergo meiosis 2, and we are going to form four spermatids. Two of them will have 23 eggs, and two of them, their chromosome number will be 23. Why? Because after meiosis 2, chromosome number remains the same. Now these spermatids, they do not have any acrosomal cap, they do not have the tail, and they're not looking like sperm. So these spermatids, now they are going to undergo transformation. There will be no mitosis, no meiosis, and this transformation is called as spermiogenesis, and this is how they form four-tailed structures, that is sperms. Two of them will have 23 X as the chromosome number, and two of them are going to have 23Y. This is how sperms are formed. Please remember, spermatogenesis begins at puberty. Spermatogenesis, where does it occur? It occurs in seminiferous tubules. Right? It happens in the seminiferous tubules. What is the size of sperm? Size of sperms is 50 to 60 microns. Then, what is the fertilizable span of the sperms? It is 48 to 72 hours. If you are asked a single best answer, you have to mark it as 72 hours. How are you going to remember it? You are going to remember it because the time taken for spermatogenesis is 70 to 75 days, on an average 72 days. So remember, fertilizable span of sperm is 72 hours, and the time taken for spermatogenesis is 72 days. Sperms attain maturity and motility. We all know sperms attain maturity and motility in epididymis, but in which part? Please remember, once we are born, we all attain motility first, and then we become mature at puberty. But in intrauterine life, it's the other way around. First, sperms are going to become mature in proximal end of epididymis, and then they are going to become motile in the distal end of epididymis. How much time is taken for sperm maturation? So the time taken for sperm maturation is 12 to 14 days. Now, suppose if you get a question that what is the time taken for formation of sperms, that is spermatogenesis, which I told you is 70 to 75 days. But if your question comes, how much time is taken to form mature sperms, then you have to include the time for spermatogenesis, which is 74 days, plus you have to include the time taken for sperm maturation, which is 14 days, and roughly we say this approximates 90 days for 3 months. It is between 70 to 75 days, so I just say it can be anywhere between 86 to 90 days. That is the time taken to form mature sperms can be anywhere between 86 to 90 days, but roughly we take it as 3 months. That is the time taken to form mature sperms, right? Then, coming to oogenesis. Now, oogenesis is going to begin from oogonia. The primordial germ cell is oogonia, right? And this oogonia is going to undergo mitosis. So we have the oogonia, which is going to undergo mitosis, and it is going to form the primary oocyte. The oogonia's chromosome number is 46XX, and after mitosis, chromosome number remains the same. So in a primary oocyte also, it is going to be 46XX. Now this primary oocyte is going to start undergoing meiosis 1, but this meiosis 1 is going to get arrested in diploidine stage of prophase, right? And this arrest is going to remain there in intrauterine life because oogenesis begins in intrauterine life. Now, in intrauterine life, nothing else is going to happen till puberty. There will be an arrest of meiosis 1, and the arrest is over at puberty. Why it is over? It is over due to the LH surge, right? And once the arrest is over, then a primary oocyte is going to form secondary oocyte and first polar body will be released. After meiosis 1, chromosome number becomes half, so secondary oocyte will also have 23X and your first polar body, the chromosome number will be 23X. Please remember, this process of release of secondary oocyte from primary oocyte is what is called as ovulation. When we say ovulation happens, primary oocyte gets converted into secondary oocytes, and the other name for a secondary oocyte is the egg. Right? So egg is actually the name given to secondary oocyte. Now this secondary oocyte will start undergoing meiosis 2, but again meiosis 2 gets arrested and it gets arrested in metaphase, right? And the arrest is over at the time of fertilization. At the time of fertilization, the secondary oocyte is going to get converted into female pronucleus and second polar body is going to be released. And this was your question on NEET PG 2024, where they said that egg is in meiosis 1 arrest or meiosis 2 arrest. Please remember, egg is the name given to secondary oocyte and it is in meiosis 2 arrest. Another very important thing which you have to remember is that the primary oocyte which gets arrested in the prophase, that primary oocyte gets surrounded by follicular cells of the ovary, and that structure is what is called as the follicle. So follicle is nothing but a primary oocyte which is surrounded by these follicular cells of the ovary. Right? Have you understood? That is what is a follicle. Clear? Okay. Then, what is the fertilizable span of ova? It is 12 to 24 hours. What is the size of a mature follicle? Please remember, the size of a mature follicle is 18 to 20 millimeters, and a mature follicle is what is called as a Brachlian follicle. If they ask you when is the number of follicles maximum, so number of follicles is maximum in the fifth month of intrauterine life, which means at 20 weeks of pregnancy, and at 20 weeks of pregnancy their number is 6 to 7 million follicles, right? Then by the time a female reaches birth, by the time a female is born, then it is 1 to 2 million follicles. That means follicles are undergoing programmed cell death, which is called as apoptosis. And by the time a female reaches her pubertal age, that time only 4 to 5 lakh follicles are present. Right? Now, remember, when there are no more follicles in the ovary, that is what is called as menopause. Then, coming to menstruation. menstrual cycle, and this is what I was talking about. This is how we are going to do certain mind maps where all the information which you need to know on menstrual cycle will be depicted to you on one page. That makes it very easy for you to revise everything in a very short span of time. So menstrual cycle, first half of menstrual cycle, what is first half of menstrual cycle called as? It is called as proliferative phase. I'm sure you remember that, and it is also called as follicular phase. Why is it called follicular phase? Because everything what is happening in the first half of the menstrual cycle is happening to the follicle. Why it is called as proliferative phase? Because the main hormone in the first half of menstrual cycle is estrogen, and estrogen proliferates in uterine endometrium. Now, if they ask you ovarian cycle is initiated by, ovarian cycle is initiated by FSH. FSH acts on granulosa cells, right? And what are granulosa cells? Just now I was telling you that a primary oocyte gets surrounded by the follicular cells of the ovary. These follicular cells of the ovary, they differentiate into granulosa cells and theca cells. So FSH is going to act on granulosa cells. Please remember that, right? So what does FSH do? FSH acts on granulosa cells. Now, what is the applied aspect which you have to remember? FSH acts on granulosa cells. It produces three hormones. It is going to produce estrogen. Specifically, it produces E2. Then it is going to act on granulosa cells to produce inhibin B. And if it is the granulosa cells of the small antral and preantral follicles, then the granulosa cells of the small antral and preantral follicles, it also produces anti-Mullerian hormone. Right? So these are the three hormones which are produced by the granulosa cells. Now, what is the applied aspect of this? The applied aspect of this are two questions. Number one question, if they ask you that in females, the receptors for FSH are present on. So the receptors for FSH, they are present on the granulosa cells. Number two, if there is a granulosa cell tumor of the ovary, that means it is going to be a feminizing tumor because granulosa cells produce estrogen. And what is going to be the tumor marker for granulosa cell tumor of the ovary? The tumor marker is going to be inhibin B, and the new tumor marker is anti-Mullerian hormone. Next very important question is, what is the effect of estrogen on FSH? Please remember, estrogen always has a negative. Similarly, please remember inhibin. Inhibin, whether it is being produced in males or whether it is being produced in females, always it will have a negative effect on FSH. Now, when it comes to the effect of estrogen on LH, LH may usually estrogen has a negative effect on LH, except there is just one exception to this rule, and that exception is when estrogen levels become more than equal to 200 picograms for 48 hours, it will have a positive effect on LH. And this is something which I want all of you to remember and highlight, that estrogen usually has a negative effect on LH, but when the estrogen levels are more than equal to 200 picograms, how much? More than equal to 200 picograms. And for how much time? For 48 hours. Then it has got a positive effect on LH. And why is this fact important? Because this is the time when estrogen is going to bring about LH surge. So if they ask you that LH surge is initiated by, LH surge is always initiated by estrogen. When estrogen is more than equal to 200 picograms for 48 hours, then it brings about LH surge. Right? Now, LH surge, if they ask you, is maintained by, LH surge is maintained both by estrogen and progesterone. Please remember, before ovulation, there is both LH plus FSH surge. There is both FSH and LH surge, but ovulation is due to LH surge. Now, the next question which they can ask you is, because I'm saying ovulation is due to LH surge, first of all, what is ovulation? I told you ovulation is when primary oocyte is converted into secondary oocyte on egg, and when follicle becomes corpus luteum, that is what is called as ovulation. Right? Now they can ask you what is the time interval between LH surge and ovulation. Please remember that it is estrogen which brings about LH surge, right? So initially the levels of estrogen will increase, and once estrogen becomes more than equal to 200 picograms for 48 hours, it is going to increase the levels of LH. The place at which the LH levels start to increase, that is what is called as LH surge. So number one is LH surge. So this is the beginning of the LH surge. And this is what they are asking, what is the time duration between LH surge and ovulation? So time duration between LH surge and ovulation, best answer is 32 to 36 hours. But if that is not given, then you are going to mark 24 to 36 hours. Right? Then they can ask you what is the time duration between LH peak and ovulation. So this over here, what is the time duration between LH peak and ovulation? It is 10 to 12 hours. If they ask you what is the time duration between estrogen peak and LH peak, so this over here is estrogen peak and this is the LH peak. So what is the time duration between estrogen and LH peak? This is 24 hours. 12 to 24 hours. Right? Now, LH is bringing about ovulation, that is definitely there. Number two, what work LH is doing? LH acts on theca cells, and from theca cells it produces androgens. These androgens, with the help of enzyme aromatase, they get converted into estrogen. This action is happening both in granulosa cells and it is happening in adipose tissue. When in adipose tissue, the androgens get converted into estrogen, the estrogen which they form is E1. When in granulosa cells, the androgens are getting converted into estrogens, then they form E2, right? So that is another work which is being done by LH. Now once ovulation happens and a corpus luteum is formed, then begins the second half of the menstrual cycle. Second half of menstrual cycle is called as secretory phase, or it is called as luteal phase. Why it is called as luteal phase? Because now whatever is going to happen, it is going to happen to the corpus luteum. Main hormone during this second half of the cycle is progesterone. Please remember, progesterone in low concentrations has a positive feedback on LH and FSH. But in high concentrations, it has a negative feedback on LH and FSH. It is the follicular phase time duration which can vary. but the time duration of the luteal phase is always fixed to 14 days. So now, next question, set of questions they can ask you on corpus luteum. They can ask you corpus luteum in a non-pregnant female is maintained by, it is maintained by LH. Corpus luteum is formed only because ovulation happens, and ovulation happens because of the hormone LH. Same function in pregnancy is done by HCG. If they ask you what is the lifespan of corpus luteum in a non-pregnant female, that is 12 to 16 days. And which hormone prevents luteolysis? The hormone which prevents luteolysis is HCG. Please do not say progesterone, it's HCG. Maximum size and maximum activity of corpus luteum it is seen on 8 days after ovulation. And if ovulation is happening on day 14, that means it is seen on day 22 of the cycle. And that means maximum progesterone is seen on day 22 of the cycle. That means because whenever progesterone is maximum, it has a negative feedback on LH and FSH. So minimum LH and FSH is seen on day 22 of the cycle. Now, if an infertile couple come to me and I want to know whether the female is ovulating or not, I have to check the levels of progesterone, and that means the tests for ovulation they are done on day 22 of the cycle. Either I can say that they are done on day 22 of the cycle, or a better answer will be 1 week before menstruation. Right? These are important questions on corpus luteum. Now, next very important point is the day of ovulation. How do you calculate the day of ovulation? Day of ovulation should be calculated as 14 days prior to the next cycle. Right? So it's 14 days prior to the next menstruation, or from the length of the cycle, you have to subtract 14 to get the day of ovulation. So suppose if your question comes that there is a female whose cycle length is 40 days, when will she have ovulation? So 40 minus 14, which is day 26 of the cycle. Now please remember, some females, they may have pain at the time of ovulation, which is called as Michel-Merz syndrome. Michel-Merz syndrome. And in Michel-Merz syndrome, patient is going to complain to you of mid-cyclical pain in abdomen every month. Now, what do you call as pain at the time of menstruation? Pain at the time of menstruation is called as dysmenorrhea. Please remember, dysmenorrhea can be of two types. It can be primary or it can be secondary. Primary dysmenorrhea is because of the withdrawal of progesterone. Progesterone is a smooth muscle relaxant, so whenever progesterone is going to withdraw, that is going to lead to vasoconstriction, and that is going to lead to release of PGF2 alpha. It is this PGF2 alpha which leads to pain at the time of menstruation, and this type of pain is called as primary dysmenorrhea. On the other hand, if pain is happening because of any pelvic pathology, then that is called as secondary dysmenorrhea. In primary dysmenorrhea, there is no pelvic pathology responsible for the pain. So the question can be asked that what is the most common cause for secondary dysmenorrhea? Most common cause for secondary dysmenorrhea is endometriosis. Right? Other causes can be adenomyosis, or it can be a fibroid, or it can be PID. All of them can lead to secondary dysmenorrhea. Questions of primary and secondary dysmenorrhea are very, very often being asked. Now, the patient profile is very different in primary and secondary dysmenorrhea. In primary dysmenorrhea, you will have a young girl who will come to you and she will say that she has pain since menarche except for the initial few cycles. Why initial few cycles? Because initial few cycles are anovulatory, and anovulatory cycles are always painless. Please remember that. Right? Or in case of secondary dysmenorrhea, you will have a reproductive age female coming to you. In other words, a female who is more than 30 years. She will say that till now she was not experiencing any pain during menstruation, but from now she has started, very recently she started having pain at the time of menstruation. In case of primary dysmenorrhea, pain is going to be a generalized pain, it is going to be a suprapubic pain. Whereas in case of secondary dysmenorrhea, pain is going to be localized to the pathology. Wherever the pathology is, pain is going to be there. So it's going to be a localized pain. In case of primary dysmenorrhea, pain is going to begin just before menstruation or at the time of menstruation, and definitely it gets relieved within 72 hours of menstruation. Whereas in case of secondary dysmenorrhea, pain begins much before menstruation and it is not relieved by menstruation. It is not relieved within 72 hours of menstruation. So in secondary dysmenorrhea, most of the cycle, meaning most of the month of the patient goes in pain, right? In case of primary dysmenorrhea, pain decreases on its own after physical activity, on its own after marriage and after childbirth. In secondary dysmenorrhea, pain increases progressively, right? Please remember, primary dysmenorrhea is spasmodic dysmenorrhea, secondary dysmenorrhea is congestive dysmenorrhea. In primary dysmenorrhea, because pain is due to the PTH2 alpha, so the treatment for primary dysmenorrhea can be NSAIDs. And as I told you, that anovulatory cycles are painless, and OCPs they make the cycle anovulatory, and that is why OCPs can be used for treating primary dysmenorrhea. In secondary dysmenorrhea, you will have to basically depend upon what the cause is. You will have to treat the cause as management. Right? Have you understood primary and secondary dysmenorrhea? Now, next coming to very very important topic, and that is drugs in gynae. I have made two mind maps where we are going to discuss everything you need to know about certain drugs in gynae. Now, when it comes to drugs in gynae, first of all, you need to know about synthetic progesterone, that is third generation progesterone. Please remember that progesterones, they are available in 4 generations, right? And as the generation increases, androgenic side effects decrease. Now, all progesterones, they have androgenic side effects, but as the generation is going to increase, the androgenic side effects are going to decrease. You all have to remember third generation progesterones names. Please remember third generation progesterones are desogestrel, norgestimate, and gestoline. Why am I making you learn third generation progesterone names? That is because third generation progesterones, they have least androgenic side effects. Right? So suppose there is a female who comes to you with PCOS and she has irregular cycles. In PCOS, we are going to do drugs for irregular cycles is OCPs. Now, in a patient of PCOS, when I am prescribing her OCPs, because progesterones have androgenic side effects, I have to be very very careful which OCP am I going to prescribe to a patient of PCOS. That is why I have to use an OCP which has got a third or a fourth generation progesterone, and that is why you have to remember the name of third generation progesterones, which is desogestrel, norgestimate, and gestotine. When it comes to fourth generation progesterone, the example is cyproterone acetate. Please remember, fourth generation progesterone is anti-androgenic, right? It is anti-androgenic. It does not have any androgenic side effects. It's anti-androgenic, the fourth generation progesterone. This is what I want you to remember about progesterones. Right. Next thing what I want you to remember is what are the drugs which are used in endometriosis for treating dysmenorrhea. Just now we did dysmenorrhea. So dysmenorrhea is a very very common complaint in endometriosis, and how you are going to treat it. The first line drug which you are going to use if a patient of endometriosis is coming to you with mild or minimal dysmenorrhea is like you treat primary dysmenorrhea. How were you treating primary dysmenorrhea? You were treating primary dysmenorrhea with NSAIDs or OCPs. Now, the second line drug which you are going to use will be progesterone. Please remember, progesterone is estrogen and progesterone are like siblings. Whatever estrogen is doing, progesterone has an opposite effect to estrogen. Right now, endometriosis is a hyperestrogenic condition. Right? It's a hyperestrogenic condition. Whenever I want to treat endometriosis patient, I have to lower the levels of estrogen. So what progesterone does is progesterone decreases the receptors of estrogen. Right? Because it has a negative impact on the receptors. It down regulates the receptors of estrogen. That is why it brings about an environment where there is less estrogen. So the second line drug which I have to use in case of dysmenorrhea in patients of endometriosis is progesterone. Third line drug is GnRH. Just now I tell you that GnRH, whenever you give GnRH continuously, it decreases estrogen. Right? Now, if the pain is not getting relieved even after using GnRH, Then you have to advise your patient laparoscopy, right? And then I am going to go for laparoscopic management of pain in endometriosis. Clear to all of you? Now, this is how you are going to manage dysmenorrhea when a patient is having minimal to mild dysmenorrhea due to endometriosis. If your patient is having moderate to severe dysmenorrhea, then OSMPs are not going to be helpful. Progesterone is not going to be helpful. Straight away, you will have to go for continuous GnRH. Right? And if there is no relief, then you are going to go for laparoscopy, that is laparoscopic management of pain relief. Right? So that is about how you treat dysmenorrhea in a patient of endometriosis.